Thank you very much, Chair. It's a great honor to be part of this intellectual feast, which actually is the only good thing that has come about because of COVID, that very many good minds gather together to try and find solutions. India is the second largest country in the world, soon to be the most populous country in the world in a few years. Therefore, the Indian experience matters for global protection in terms of how much of immunity is achieved at the population level and whether not only the people are protected, but whether any variants can possibly emerge from India. Therefore, looking at the kind of statistics that we have, India ranks number 3 in terms of the total number of deaths in absolute numbers. However, we know that if you adjust for the population size, certainly the deaths per million are much lower, being only 332 per million, much lower than North America and Europe and several other countries. This is partly because of the relatively younger age structure in common with other South Asian countries, and also because 2/3 of India is rural, where the transmission is slower and comorbidities are lower, and therefore there is a certain level of protection. However, in absolute numbers, it still does pose a major challenge to the health system and the economy. The experience of the first wave started on 30th of January, when an Indian student came back from Wuhan with the virus. In February, tourists from Italy were found to have the virus. And later on, President Trump's visit, which resulted in mass gatherings to welcome him, also spurred the pandemic. And then we had religious gatherings in March of 2020, also sports tournaments, all of which added to the numbers. Nevertheless, the cases were still very few, still in a few hundreds, when the first wave lockdown started on the March 24th and 25th midnight. And it was more preemptive in nature, seeing the kind of huge havoc that the pandemic was already causing in Europe and North America. We had a prolonged lockdown, almost 2 months, stretched in stages till the end of May, and in some states went even up to July. The wave mounted from July onwards to reach a peak in September and started subsiding in October of 2020, and by January faded fully. It was mostly confined to the urban areas and was predominant in some of the more developed parts of India, which had international airports where the virus landed and spread to the surrounding districts apart from the big cities. But the rural areas were considerably protected. Initially, India followed, apart from the prolonged lockdown, recommendations for physical distancing. The knowledge about masks came much later, even from WHO, but India started following the East Asian and Southeast Asian example from June and July, recommending masks, and apart from hand washing. But there was extensive supply chain disruption and also great shortages of test kits, personal protection equipment, and ventilators. And therefore, India started looking for self-reliance rather than depending upon global supplies, and started looking for building makeshift hospitals in order to strengthen the limited healthcare capacity that was there across India. The lockdown did have an impact in terms of reducing the initial transmission and the deaths, as well as the case numbers, while the systems were being strengthened. And the center-state coordination in a federal polity between the central government and the state governments was quite strong. However, the prolonged lockdown imposed suddenly had tremendous humanitarian consequences for the migrant populations living in the urban areas who were locked in there, and we did not have adequate support. And their trek back to the rural areas later on was also considerably tragic. The weaknesses were very clear, that we did not have an adequate healthcare infrastructure at that point in time. And like many other countries, we learned that unless you have an efficient and equitable health system functioning well in the steady state, you cannot build a surge response which is strong and swift when challenged by a public health emergency. We started celebrating our victory rather prematurely, and contact tracing was rather poor, and primary care facilities were not active because it was considered to be mainly a problem of the big hospitals and the ventilators, and the community was not adequately engaged. Even in terms of testing, we had initially great shortage of tests, but then the rapid diagnostic tests were also being used. But different states used RT-PCR and the rapid diagnostic tests in different levels, and we started learning about false negatives and also about some degree of false positives as well. But the biggest challenge was, even in terms of measures, the R value. How do you actually calculate a correct R value when many of the people who are infected are asymptomatic, and all of the people who are symptomatic are also not being tested? Secondly, even the test positivity rates can be fallacious when testing is inadequate. So there are a number of issues that concern even the nature of using the tests appropriately and interpreting them appropriately. In terms of vaccines, the preparation started even as the first wave was progressing. And then we contracted AstraZeneca for production of the vaccine in India, in the Serum Institute of India, but also started producing an Indian-made vaccine, which was made of an inactivated virus, and started trials. This was completely developed by the National Institute of Virology and then contracted out to an Indian company, Bharat Biotech, and clinical trials were also started. At the same time, other vaccines also started getting into the development pathway. And emergency use authorizations were given early in January, even before the phase 3 trials were completed. This drew criticism, but it was considered that it was important to do so because the alpha variant had already landed, and it was thought that it was important that we prepare with vaccines in order to combat the expanding epidemic if it did come. We started our vaccination on the 16th of January 2021, initially keeping the vaccine eligibility as 60 plus age population, as well as people with 45 years of age and with diagnosed comorbidities, then changed it to all people above 45 years and people above 18 with comorbidities. And then later on, from 1st of May, we said all adults aged 18 and above will be vaccinated. But at this point in time, because there was some confusion about the procurement of vaccines, the pricing of vaccines, and the distribution of vaccines between the role of the center and the role of the state governments, the distribution between the public sector and the private sector, between April and June, there was a considerable amount of confusion. But by June, it became apparent that the central government had to take the responsibility for procurement, both domestically and globally, and that the public sector was predominantly the vehicle for delivering the vaccines because the private sector did not have much of a presence in smaller towns and villages. So these were some of the learnings that we had. And even other vaccines started getting developed in this way. In terms of the first wave lessons, the lessons were you have to depend upon self-reliance substantially, even in a globalized economy, because there are supply chain disruptions which can greatly set you back. And when every country is on its own competing for scarce resources, it is better that you have certain level of self-reliance. And India proceeded on that path after the first wave. And there was good center-state coordination initially in the first wave, which was not there during all part of the second wave. But one of the other elements that we learned is that all these mathematical models of prediction were inaccurate because they did not take into account the behavior of human beings. They only took into account the behavior of the virus. And they did not take into account the variants coming in, whether people are wearing masks, whether people are having super spreader crowded events, and therefore virtually every single mathematical model wrongly predicted. The other element, of course, is in the second wave came in because between January and March of 2021, there was a false assumption that herd immunity had come in, and the mathematical models also predicted that there would be a second wave, and therefore policymakers as well as the public decided that we could actually turn our back on the virus, even though the virus had not turned its back on us. And we found that because of this lockdown being replaced by laxity, false predictions, and other priorities emerging like elections at the local level as well as the state assembly level, interest in accelerating economic growth, religious gatherings, large mass gatherings, we created an open highway for the virus to travel. By early January, we already knew that the Alpha variant had landed. And by February, March, we knew that the Delta variant had emerged, though it was diagnosed only in March. By February, we had early warnings from Mumbai that the cases were increasing unpredictably, unexpectedly. So we recognized that the advent of the variants also created a great rise in the number of cases. By mid-March, the second wave started, the surge started, it peaked by mid-May, but it petered by end June, by which our antibody seropositivity rates in the population had gone up from 22% to 67%. So we had a considerable amount of population exposure. Unlike the first wave, now the rural areas were widely exposed, and therefore the virus had a free passage everywhere across India. And we, however, did see differences between the states which used non-pharmacological interventions like masks and trying to do contact tracing and trying to prevent super spreader events, slowed down the transmission. They spread out the second wave, whereas others had a huge surge as well as a sudden decline when large majority of the people were already infected. And we saw this difference also between Odisha and Karnataka. In Odisha, where the mean growth rate of the tests was higher than the mean growth rate of the cases, we had a much better control than in Karnataka, where mean growth rate of the cases was higher than the mean growth rate of the tests. The lessons from the second wave were that do not declare victory prematurely. Sero surveys are useful for tracking population exposure to the virus, but are not proof of individual immunity and certainly not of herd immunity. And that herd immunity is a fallacious concept, because even if a large section of one population in a city does get exposed and have immunity, if the non-immune section of that population travels elsewhere to other parts of the country or other parts of the world where the virus is still in active circulation, they have no protection. Therefore, immunity here is a personal attribute, not a population attribute. And therefore, that is something that needs to be remembered. And therefore, the emergence of variants changed the dynamics of transmission rates and susceptibility. The other lesson is do not dismantle facilities that were created in the first wave or the earlier wave, which we did. And then suddenly we had to scramble back to set up facilities again in the second wave. We need seamless center-state coordination in any federal polity. We need primary care. Primary care is absolutely pivotal. People focused on hospitals and ventilators, but right from early case detection based through symptom-based syndromic surveillance, early testing, triage for deciding on home care versus hospital care, in terms of building vaccine confidence, in providing chronic care for long COVID cases. Primary care is pivotal, and that cannot be neglected. And this is one thing that we clearly recognized during the COVID period. We also realized that genomic testing needs to be stepped up for early recognition of variants. And then we also decided that we need to fight this battle by covering both the flanks. One flank is increasing vaccination, other flank is to be protected by COVID appropriate behaviors. So we need to protect both the flanks as we advance. In terms of vaccines, India has been focusing a lot on vaccines as well as drugs, of course. But in terms of vaccines, apart from the two vaccines, that is the inactivated virus vaccine as well as the virus vector vaccine, Covishield, we now have the J&J vaccine being produced in India, Sputnik vaccine being produced in India, Novavax being produced in India, but also India-made vaccines, India-developed vaccines, which is a viral subunit protein vaccine, a DNA vaccine, an India-made mRNA vaccine, and mucosal vaccines, which can be nasally administered, are all under trial stage and are likely to get through the regulatory pathway if they prove their mettle in the trials. So by early January, we'll have several vaccines made in India, some of which will be available for the global supply chain as well. So India is investing heavily in vaccine development and manufacture. At the same time, the drugs which have been mentioned, molnupiravir, 12 Indian companies are now going to make molnupiravir, 8 licensed by Merck, but 4 have developed it on their own. So again, even in terms of drug supply globally, India is ready for that. But we have learned our lesson that you cannot have a weak health infrastructure. The government is investing much more in infrastructure, health infrastructure as well. And suddenly it's realized the importance of rural and urban primary care, of secondary care, of critical with oxygen supplies, because we were very short of oxygen supplies at one point in time. So investing in all of that, in critical care units and effective surveillance systems, including One Health, building up facilities for looking at zoonotic disease transmission in One Health. And that's where I'd like to conclude. We cannot think of pandemic response as only limited to case detection and management. We cannot even think of it only as surveillance among human beings. We have to think of it in terms of One Health eco-surveillance from wildlife to veterinary population to human beings. But we also have to think ahead in terms of pandemic prevention by way of preventing deforestation, of large-scale animal breeding for animal feeding, for both for consumption of animal foods, meat consumption. And therefore we need ecological sanctity and environmental sanity. That is something that we need to look at if we're going to prevent future pandemics. And that is needed for future development. And that's the learning that we need to take from this pandemics. So thank you very much.